Chairman, دايما متشكر على الدعوة الكريمة ودايما it's a pleasure to be among my sisters and brothers في القصر العيني ودايما متجمعين في الخير دايما. My topic will be about hepatocellular carcinoma, which is beyond the standard of care. My agenda will be tackling the following points: disease background, immunotherapy, which I think it's a hot topic in our branch, and evolution of first-line treatment in advanced unresectable HCC, and I'll come up to my conclusions. Liver cancer, as we all know, is a global health issue, and it's the second most common cause of cancer-related mortality. Also, it is gaining a recent incidence in females as well as males. Now, in our Egyptian registry, and what about our screening, which is done using abdominal ultrasound and plus or minus alpha-fetoprotein? Now we are gaining much tackling in this issue, and I can see that the target population, the cirrhotic patients and non-cirrhotic patients, but carries a high risk like hepatitis B or alcoholic or any FLD or acute hepatitis C. The endpoint is obtaining a primary liver cancer diagnosis at an early stage and improving survival. What is the pathogenesis of HCC? As we all know, it is chronic irritation or chronic damage. Most common is used for viral hepatitis B and C, alcoholic cirrhosis, hemochromatosis, or aflatoxins. Of course, the most recently common used scoring for the liver functions is the ALB score. Now, it is important to emphasize that we are tackling two diseases and not only one disease, which is cirrhosis and HCC. So for our staging, we have, based on the BCLC update, a very early intermediate, which is BCLC type B, and advanced disease, which is more or less related to the oncology treatment. I find it like an interesting paper. For example, in a study comprising 237 patients diagnosed with unresectable HCC, roughly 57% passed away due to cancer progression. On the converse, the remaining 43% faced mortality because of complications stemming from the underlying cirrhosis, which includes sepsis, gastrointestinal bleeding, and renal failure. So I was just trying to emphasize again that we are dealing with two diseases. So why do liver functions decline in HCC? Acute decompensation due to primary liver cancer, viral hepatitis reactivation, treatment-induced liver toxicity, which is very important, dehydrated patients, infections. And in case we have a reversible etiology, then should be treated aggressively to preserve patients' liver function. Again, I'm trying to outline the importance of MDT, which really takes in consideration the hepatologist, the radiologist, and the oncologist, as well as the pathologist, trying to optimize the care for the patients. In two recent papers, patients seen by an MDT approach helped in improving the survival in patients with a metastatic HCC patient. I won't go through the BCLC staging. I think all of us we are really aware about. This is the 2022 update. The treatment strategies for the HCC falls into four categories. On the left side is a curative intent, which is basically surgical resection or doing a liver transplant. And on the right side, which is basically starting from BCLP type B, including local regional therapies, systemic treatments, and in case of advanced disease, we go for best supportive care. Just a very short insights about the surgery: a curative option in which the patient diseased liver is removed and a healthy liver is transplanted. In the United States, it offers a 5-year survival rate of 55 to 80%. 70 to 80% of patients who undergo surgical resection will have a disease recurrence within 5 years, but surgical resection can give patients more than 60% chance of surviving for 5 years. What about local regional approaches? We have the ablative therapy can be curative, like the RF for lesions less than 2 centimeters. Ablation techniques include radiofrequency, microwave, cryotherapy, which is now currently obsolete, and percutaneous ethanol injection. Embolization is a standard of care for the intermediate stage, class B, and it involves transarterial embolization or bland transarterial embolization, TACE, transarterial chemoembolization, or taste with drug-eluting beads, and recently of gaining interest, the radioembolization TARE, or selective internal radiotherapy. This is important to emphasize that BCLC type B patients are a broad spectrum of patients. You can have a multinodular, and you can also in a preserved liver function with a performance status of 0. And you can go for bridging in these patients, where you can start by doing a local regional treatment followed by systemic, or you can go for a transplant. This is one of the options we can offer in clinical oncology, which is SBRT. It's called stereotactic body radiotherapy. What we do that we give high doses of radiotherapy. It's more or less like ablation. However, in comparison to ablation beats SBRT in current studies, but it is a good option to have in our department. What about chemotherapy in hepatocellular carcinoma patients? I think most of us are aware that HCC is a kind of chemo-resistant tumor, could be related to expression of drug-resistant genes. Treatment options over the years failed to gain any benefit. Using our molecules, I'll try to be very simple in this area, because I know chemotherapy is a bit harsh to understand. So using agents like gemcitabine, oxaliplatin, cisplatin, capecitabine, doxorubicin failed to improve survival. Now this led us to the introduction of immunotherapy. It's a bit complicated, so I'll try to simplify my diagrams. So what is the main cause of HCC? It is chronic inflammation or chronic irritation of the liver. H, using viral hepatitis, causes chronic hepatitis, which causes tissue damage. Necrosis regeneration causes the release of excessive growth factors. Continuous regeneration means higher risk for gene mutations, and probably HCC will occur in most of these patients. Now, this is what we call the tumor niche or tumor microenvironment. It is a complicated, and it includes a system of endothelial cells, fibroblasts, immune cells, and cytokines. On the left-hand side, these are tumors. These are cells in the niche, which has an anti-tumor effect, and on the right side, cells which has a pro-tumor effect. So what immunotherapy will work on, it will try to suppress the cells on the on the right side, which have the pro-tumor effect. It is a process that begins using the innate immunity of the human being, and then it translates into an adaptive immunity, which a process called priming or clonal expansion, where the T lymphocytes attacks the tumor microenvironment and try to suppress the tumor activity. So how can the tumor escape this? The immune response to cancer can be dysregulated by either failure to recognize the tumor or an environment around the tumor that blunts the immune response, which was just seen in the last slide. Upregulation of some immune cells which have a pro-tumor effect can cause to resistance to immunotherapy. Just a short glimpse on how TKIs, the sorafenib and lenvatinib work. They work through inhibiting the downstream activation of a wide range of growth factors which are involved in tumor growth, like the vascular endothelial growth factor, epidermal growth factor, and platelet-derived growth factor. What about the beva or bevacizumab, Avastin, as we all know, this target therapy? It's an anti-vascular growth factor which upregulates and releases vascular endothelial growth factor, which promotes angiogenesis in the tumor, and then it could some common side effects include thromboembolic events, hypertension, proteinuria, and bleeding events. Now, just take you step by step through the evolution of HCC treatment. TKI, which started 2008. The most common is sorafenib. Using the SHARP study, it gained an overall survival compared to placebo. And then 10 years after, we got a new molecule called lenvatinib, and the trade name is Lenvima. In the REFLECT study, it was non-inferior to sorafenib. However, as we all know, the TKIs usually have some side effects which could cause quality of life of the patient not to get better. So this is sorafenib, as we all know, the SHARP trial, overall survival advantage. Lenvatinib versus sorafenib was non-inferior to sorafenib in overall survival. And then we go through the immunotherapy combinations, or immunotherapy plus vascular endothelial growth factor, which is the EMBRAVE study. It's atezolizumab, which is an immunotherapy, plus beva, which is an anti-vascular endothelial growth factor. The study design was compared to sorafenib, which is the standard of care at this time, and the results were really impressive, and the overall survival were better in the atezo-beva arm. New strategies. This is a dual immunotherapy. It tackles two molecules, which is tremelimumab, or called Imjudo, and durvalumab, which is called Imfinzi. This is a very recent protocol called the Himalaya study. I'll take you through the Himalaya. I don't think we need this really complicated slide, so I'll try to skip it. How the tremi enhances an anti-tumor immune response by blocking the cutaneous T lymphocyte antigen 4, expression of PD-L1, which is a programmed cell death receptor on the HCC cells, continuing to contribute to immune suppression. While Imfinzi, which is an anti-PD-L1, blocks the PD-L1 interaction, and such blockage strengthens the pre-existing anti-tumor T cell responses, which could cause to a prolonged survival benefit. This is the study design: unresectable HCC, child PU class A. This is the dual, combination, tremelimumab plus durvalumab versus durva alone versus sorafenib, or versus a higher dose of durva, and then the outcomes were really also in favor of the dual combination, the durva tremi. Now I just added this slide before I come to this conference, because 1 week ago we just got a new approved combination, which is nivolumab plus ipilimumab, which is again an anti-CTLA-4, and it just gained the FDA approval, and currently or shortly it will come in the guidelines. So now I think we are gaining and having many treatment options in HCC. It's important to say that in the Egyptian Ministry of Health, and currently in Qasr Aini as well, we started to recruit patients to receive immunotherapy, which I think is a new milestone, a new era, having such both the atezo-beva arm and tremi-durva. It all depends on special indications in which line to choose, but we are currently started to recruit these patients in Qasr Aini. Now I come to my conclusions, and I'm sorry for exceeding my time. Patients at risk are patients who are having cirrhosis. For BCLC 0 or A, options include surgery, transplantation, or ablation. For B, definitely local regional therapy is the standard of care. Chemoembolization plus or minus lenvatinib, which is coming very shortly as well as a sort of combination in BCLC type B. The role of SIRT, radioembolization, is still uncertain. For BCLC-C or BCLC type B following TACE progression, you can go for atezo-bev, durva-tremi, or nivo-epi, which is coming shortly. TKI, sorafenib is equal to lenvatinib, and then in case of future progression, options of second line would include also multiple TKIs, such as regorafenib or ramucirumab or cabozantinib. For BCLC type D, focus on best supportive care. And I thank you very much for your attention.